Jonathan, thank you for inviting Emma and I to your rooms here in Harley Street to, I think, try and pull together a discussion which we've been talking about for a while now. Emma and I are working at the Evewell, not so far from here, and with your experience in male fertility, your suggestion of getting 3 people together from the male fertility background, the laboratory, and also from a female gynecological point of view would be a really helpful discussion. So thank you. Can I kick off by asking you, you've been working in male fertility for more than 40 years, perhaps before even IVF began, I believe, and so you've got a huge amount of experience. Where do you start with male fertility? Because I think it's the sort of forgotten part of IVF quite often.
Well, actually, the business of having done this for 40 years is quite a good place to start, because indeed it was before ICSI.
Yeah.
It wasn't before IVF, because there was IVF just beginning at Bourne Hall and Hammersmith, but it was before ICSI. And therefore we were, as urologists treating male fertility, there wasn't much that we could do. We recognised, however, that varicocele was relevant to semen analysis, relative to delay in first pregnancy. And so there were lots of old-fashioned open operations for varicocele. And therefore, before ICSI, those of us who were doing that before ICSI sort of realised that varicocele treatments worked. But the other salient point about being as old as I am, there was only one way of measuring whether it worked, and that, of course, was a natural conception and a live birth. One couldn't really measure it in pregnancy rates and numbers of embryos, pregnancy per embryo transfer. It was whether nature took its course, having had an intervention, in this case, an operation. So actually, it was very useful. There are not many ways in which it's useful to have done 40 years, because that means one's pretty aged. But it was certainly useful in terms of having a feel for, yes, treating varicoceles, but actually more broadly than that, yes, treating male fertility.
I think broadly, when you look back with all that experience, you have the clear view that obviously male factor has a huge influence, not only in natural conception, but also in terms of what we can achieve in the fertility clinics. But when you put it all together, when you think about what Emma's doing with the eggs that we can give her through careful stimulation, to what degree do you think the male factor in patients that are untreated or have no input at all about male factor with just perhaps a basic semen analysis could be having on our success rates? Do you think we could be that much better with our success rates across the UK?
I think we probably could. If you look at the change in published data, and of course we know about published data, because an awful lot of the new paper or the new textbook actually lifts a few chapters from the last paper or textbook. So for many years, 20, 25 years, Emma will remember, and I'm sure you read too, that the male factor accounted for 30%, maybe 25% of loss of first pregnancy in a couple. Well, the most recent textbooks and papers are now talking about 45, 50%, and they are all following each other. Now, whether there is absolute clear data that could be translated into evidence is another matter. But biologically, it would be very odd if the male factor wasn't half the problem. And indeed, if demographically we are looking and socioeconomically at an older age for couples and women to attempting first pregnancy, then of course the male factor becomes more relevant, because what might have been accommodated for by much younger eggs, a much younger woman, now no longer can be.
Before we get on to what Emma sees in the laboratory, how do you approach that male patient that comes to see you for the first time? And often it may come with quite a story, actually, or a long background of perhaps failed cycles, lots of emotion that's involved with trying to cross the line to achieve a pregnancy. How do you approach that couple, but specifically that male patient?
So I think approaching the couple who failed many interventions is completely different from approaching the subject of male fertility or infertility. That's partially because you look at a semen analysis and you look at the man, and it's difficult to know in the absence of a history whether that semen analysis represents a fertile or an infertile state. But by the time you get to the patient that you're describing, with 2, 3, 4, maybe more failed cycles and a period of time trying to conceive naturally before that, then of course there's a problem. My standpoint is that often by that stage it's a problem shared. But the only thing that we might be able to correct with some degree of certainty might be the male factor, particularly if that has been previously ignored. And of course, I'm well aware that fertility clinics, embryology labs differ hugely in their approach, their capabilities, and therefore the prospects of success when others have failed. But I regard my role as pretty humble, really. There's only one question. Can we improve this man's fertility? Might not be the same as improving his sperm count, which he will be hung up on because everybody's told him that the cardinal importance of morphology, for example. We might not improve his semen analysis, but we may well improve his fertility by other measurements, possibly the DNA quality of the sperm.
And you talked a bit about varicocele, other things, infective causes. What proportion of today's group of patients that come through would you say are structural problems? Infection is always that sort of that hidden thing that no one can see visually or perhaps feel, so you wouldn't know as a patient. But are you seeing more infections over your career with men coming through, or is it less?
Well, I think we've probably got to change our medical language a bit with this word infection, because as you say, infections are associated in most people's minds, including doctors, with symptoms. And of course, the men who may have an abnormal balance of organisms in their seminal fluid do not present as if they have what we all regard as an infection. So the thing gets off to a bad start. And I prefer to call it, a word I think we will use more commonly in the future, a dysbiosis or an imbalance of the germs that are there anyway. And I think that that is a relatively frequent finding in that population who are not necessarily infertile, but certainly subfertile. And
Emma, do you think, could you talk us through some of the things that we see? Because we work together and have done now for over a year at Evewell, but what sort of things do you see, or what tools can you see in the laboratory that help us understand whether this is more male or female, perhaps influencing the outcome? And of course, it's not usually one thing, often it's usually a combination. But how do we begin to unpick that?
So I think you probably need to go back to what you said about having 40 years in this. I'm 21 years into this now. And I think if we go back to why, I think the element of why we've missed it for so long, or we've not focused on it for so long, is because we just didn't have the capabilities to see the embryos and the impact of male fertility until quite recently, really. Back in 2003, when I started embryology, we were growing embryos to day 2, maybe day 3. At a push, we couldn't get them any further than that. They were in closed incubator environments. We were only using ICSI for the absolute worst case scenario. We weren't using it as frequently as we are now. So I think actually as embryology has evolved, so has our understanding of what normal is and what normal looks like, and therefore when it is not normal, why it is not normal. And I think actually time-lapse has been, for me, the biggest understanding of what an embryo should do, why it doesn't do it, and when it doesn't do it, and what all that means. So for me, in the lab now with time-lapse, able to grow embryos day 5, day 6, day 7 confidently with what I now know to be significantly structured percentages of what a certain woman of a certain age should end up with in a group of embryos in regards to how much should be growing. I think you can start to then look at the morphokinetics of embryos and see where they are failing. So I think if you think time-lapse has been around 8, 10 years, our understanding of the impact of the male factor on those embryos' development has been huge, and it's definitely driven by what we can see. So to answer your question, an embryo that is dividing normally for its first, second, and third division, so going from a single cell to 2, 2 to 4, 4 to 8, has fundamentally got the best potential to go on to create a pregnancy. Thus, if that then goes on to fail in a woman that is of a good reproductive age of under 38, I think we have to be raising red flags that actually something is fundamentally going on, as we know the sperm kicks in late day 3, early day 4, that would raise alarm bells for me, and I think it should be much more prevalently looked at. And I think that it comes from the technology increases. Embryos that develop abnormally from that first division, we very much know that that probably is driven by the egg, but that doesn't mean there's not a male factor there. And I think that that can be missed as well. So I think as embryologists, we are only just seeing this in my world and understanding it a bit more. And I think it's all come about because we know what embryos, we've got so much representation of how they should morphokinetically be developing. And I think now we're starting to really hone in on what causes what.
I think absolutely. And it is sobering to reflect that we are just beginning as a group of specialists to be able to have this conversation about the embryoscope, about what's actually happening in the lab, whereas only 20 years ago, as Emma's saying, there was a terrible worry about doing ICSI. Would you damage the egg? There was a worry about keeping those embryos for too long. Would they just fall to bits? And of course, against this background of uncertainty and feeling our way for so long, people have been talking about, as we do in medicine, not so much possibly scientifically, because scientists use the word evidence properly. But Ed and I have been talking about the evidence in inverted commas, when actually this hasn't been evidence. It has been a series of observations based upon data. And when the observation is long enough and the data are big enough, we begin to get the drift and move on to the next thing. But we've been terribly held back by this notion of evidence. And we all know we can only get that by prospective randomization of two human beings who are often desperately worried and emotionally damaged. You cannot randomize these people to different treatments in order to get a scientific answer. So we come back to observation over many years and making many observations and then creeping forwards. But I think we're creeping forwards rather more quickly in the last 3 or 4 years, I would think.
I agree. I think certainly I've seen in my slightly shorter career, I've definitely seen the narrative change in terms of the impact male factor fertility can have. And I don't think it's right that couples should be 4, 5, 6 cycles in before we then decide that there may be something that needs further investigation. I think the hardest diagnosis, which often come up against, is the unexplained patient. And I wondered how you would sort of tackle that, or suggest tackling that awful diagnosis. Emotionally, as a couple, to be told there's nothing that we can do, just do an IVF cycle, needs to be thought through carefully.
Well, absolutely. But it's not just that the word unexplained is an unsatisfactory diagnosis, because of course it isn't a diagnosis. But the word itself is unsatisfactory intellectually, because it's sending a message that, firstly, nobody knows, but secondly, sort of that nobody cares. Because as you just said, Ed, the solution to that diagnosis of unexplained infertility is yet more of the same. which hasn't worked in the past. So I think we ought to abandon that. And I think we also ought to be, that title, because I think often it can be explained. The DNA fragmentation might explain the at least temporarily unexplained. But then, of course, we've got to try to explain the reason that the DNA quality of the sperm is reduced. And I think we're just beginning to do that. And we're also just touching upon, beginning to understand that often things that we cannot see and cannot measure about the sperm DNA might be responsible for poor embryo development. And so there's a long, long way to go here, but I would favour ditching that word unexplained. Whether we ought to be very careful about the label that is male factor would be another worry for me, because of course we've all seen patients who've had a natural conception. They come along and the man has got a very, very low semen analysis, a low sperm count, low motility, and everybody sort of wonders and brushes over it. But in fact, of course, he may well have had that when he conceived their happy little child, now 4 or 5 years old. So he certainly didn't have, in inverted commas, male factor anything, because he was not, by definition, infertile. So I think we've got to be quite difficult with that, and we're careful with that diagnosis, because here's the man with his baby and his wife sitting in front of us, and we're putting a label of male factor on it. Well, hang on a bit.
You talk about DNA fragmentation now, which has obviously become much more popular in recent years, much more available. I think more people understand that it's a test. But could you just talk a bit about what it is and what it's trying to determine in terms of male fertility?
So I think it is useful, first off, when we have a typically unexplained situation. It may be primary infertility, it may be secondary. But whatever is happening here, there is either a delay to conception, first conception, followed by a bit of IVF, which might have worked historically but now isn't. But this is explaining the DNA fragmentation, the fact that things are not as good as they should be, given his age, her age, the results of the semen analysis. We would all think, well, they should have succeeded either naturally or in their first or second cycle. And as Emma touched on, they often fail to succeed in the cycles of treatment when the embryos don't go beyond day 3 or day 4. And then one can say, oh, well, this is probably due to the DNA quality of the sperm, and that's where we may be able to influence this positively by treating a varicocele, by identifying a dysbiosis, some organisms that might be causing a bit of inflammation. And of course, we mustn't forget the enormous impact of lifestyle.
Don't you think it's sad, though, that, and from an embryology perspective, I find it incredibly disheartening that there are still so many places and referrals going on for unexplained infertility that are using a between £6,000 and £10,000 IVF cycle as a diagnostic route. Should we not be going there first before we go into the IVF cycle?
Absolutely. And I couldn't agree more. And in no other branch of medicine do we fail to investigate 50% of what could be the problem, let alone fail to treat it. And I think it's because in no other branch of medicine are our so-called treatments, in this case IVF and ICSI, entirely binary in outcome. So there is nothing between success, having a baby, and failure, not having a baby. There's no improvement, there's no mitigation, as there are in many other conditions. You go and see your doctor with a painful joint. It's not the case that it's either cured or remains precisely the same without a diagnosis. And I can understand how this has happened. It's happened actually because of the miracle that was ICSI.
Yep.
Because this was so miraculously that everybody thought, well, that's got to be the solution. Now, it was the solution, but only maybe in 30% of people. But we sort of forgot that bit and just went on practicing the miracle.
I agree, and I've seen this many times, and we've talked about it. It's such a difficult conversation when you have a couple that have perhaps tried for 2 or 3 years. They've had some basic tests. They've even perhaps had, a long referral process to get through to their cycle. The only thing they want to do is to start treatment.
Yep.
And having the ability to take that broad picture, look at all of the factors, whether that be age, health of the patient, health of the man, and be able to say, well, actually, I think you benefit from 2 to 3 months of preparation is a really hard conversation.
Yeah.
It's very, very challenging. But you will see the effects of high and low DNA fragmentation in the laboratory in terms of what we're seeing with the embryo.
Yeah, so I think we're, as a clinic, and like if we take a step back, I think as a profession, embryology is a far more respected profession than before. We have a lot more say in what goes on. We have a lot more, I mean, if you think back to when embryology started, when Jean Purdy, who was a nurse, and embryology has become such a refined profession now that in our own right, we are clinical entities that support the doctors in their day-to-day. And that wasn't how it always was. We were very much deemed lab technicians when we first started doing embryology. So I think actually that relationship and that conversation needs to be had to where we're making such big breakthroughs is the fact that as embryologists, we are very, very highly clinically trained. So we are able to now start drawing our own conclusions. But I also think that as a clinic, we are very proactive at trying to manage that desperation to start treatment, but equally not wanting to use that first IVF cycle as diagnostic. And I'll be completely honest, that if I've got a couple sat in front of me that's 18 months into a fertility journey and there's been no conceptions and we've got no reason why, I am going to do ICSI, because I do know that, you've just said it, it is the miracle that actually in some places can work to do what nature isn't doing. I still don't think that's the right approach, but because I do think we need to investigate more. But yes, so from an embryology perspective, I think that you can, back to your point about seeing high and low DNA frag, I think high DNA frag, moderate DNA frag can sometimes be overcome a little bit with the ICSI process. I think if it's obviously really high, you won't get great embryo development. You'll get delayed embryo development. You definitely get embryos that are taking the full 6 or 7 days to form into a blastocyst entity, which does not correlate to good pregnancy rates, regardless of genetic status of that embryo. But I think there's a real balance on how high it is, and I think you're probably very clear on the type of DNA fragmentation it is to what we then see in the lab. But I think productively as embryologists, we are being a bit more brave with our use of micromanipulation tools to create embryos, and I think it's incredibly successful.
And on that, I guess both of you, I suppose, on sperm selection techniques, because there's a million of different techniques that are favoured in different clinics with a lot of studies which are probably at the bottom of the evidence-based pyramid with no clear direction of which one is more superior. Can I draw you on what your thoughts are on different ways of selecting sperm before you do the ICSI?
So I think that's largely Emma's task, but I regard my task as to be able to identify a possible and treatable cause for the increased fragmentation, for the poor quality sperm. And it does have to be said, as Emma is saying, that the whole context is important, because you don't want to use a test to put a stamp, a diagnosis, onto any person, whether male or female, which seems to be unchangeable. Because once you've said there's a problem with your DNA, which there may be, but it may be a recoverable situation, then we've sort of crossed a bridge. We've reinforced a diagnostic label, and we must be very careful of doing that. And so DNA fragmentation may not be entirely relevant to that couple's situation. They may be one of those couples with a low semen analysis, poor fragmentation had it been measured, yet they have a little baby. And of course, it is for that reason that many doctors, both urologists and gynecologists, will say DNA fragmentation doesn't matter. It's expensive and you can't do anything about it anyway, so why measure it in the first place? I take a completely different view because I think that in probably 1 in 3 men, you can improve it. Maybe 50% of men, having found a reason, and having improved it, it is pretty likely, isn't it, Emma, that we'll get better embryos.
Oh, absolutely.
I mean, it's pretty likely. Again, you know, people will say, give me the evidence, and I will counter that by saying almost impossible to get, particularly with DNA fragmentation, as there are 4 or 5 different ways of doing it. And because it came from scientific laboratories, powerful scientists who devise these tests will all aver that theirs is best. So it's a bit tricky for the clinicians to be doing studies when they're using different tests and therefore may not be comparing like with like.
Absolutely. No, we see that all the time. Lots of questions around all these different techniques, and it's a really hard one to answer. Actually, I don't know if you have more. You probably have more conversations at the laboratory, because one of the things that we try to do at Evewell is to make sure that the embryologists who for years have been hidden away in laboratories and don't speak to patients apart from with outcomes actually have a consultation, which is really important. I think patients really value that. But you must get a lot more questions around this when you get to those patients that have perhaps been through more than one round of treatment and seen differing outcomes.
Yeah, we do, especially if they come from other clinics and they've seen poor embryo development. I have quite structured questions I'll ask them to make sure I can see where that's coming from. And if something glaringly obvious comes up for me, then it's a referral straight out to be a urology through their practicing clinician. But I think engaging your embryology team more is absolutely the right thing to do, because we will see things. We will see things that our gut feelings are just not right. It doesn't look right. The embryo development doesn't look right. And we've normally got a fairly good idea where it could potentially be coming from. And then when you start asking the right questions and engage the professionals, you definitely, I've seen different cycles of IVF, mainly ICSI with recoverable, and they've spent that 3-4 months, completely different embryo development outcomes. And ultimately more embryos is a selection tool for more babies.
And of course, it's only by having this conversation, but having a multidisciplinary conversation, the MDT, as has developed in just about every other medical specialty. It's only by having that conversation that we, Ed and I, can learn exactly what the embryologists see, i.e. better embryo development, or worse. But I think the next stage, we have the MDT is just, as you know, Emma was at the Lister, and we've created an MDT there. But of course, once you've started it, firstly, quite rightly, it's unstoppable. And with the sort of complexities that we see in the female side, the male side, and in the laboratory, actually, these are long and complicated discussions. I think we will learn a lot from doing this. But doing this, I think we must, or we will not move forward.
I agree. I think that really considered view of when to sort of begin treatment, you can't just look at one entity, you've got to look at the whole picture. What's lovely is actually to run things on parallel tracks sometimes. So it's not that you're saying you shouldn't start or you can't start. It may be that actually the referral begins and improvements begin to be made, and you agree signposting to when there are times when you'll retest, recheck, reinvestigate, or perhaps begin treatment. But yeah, I've seen it many times. There are, of course, the challenges of increasing maternal age, low egg reserve, which we have to measure. But for me, I think sort of bringing the whole thing together has got to begin that conversation of, it's the Sir David Brailsford approach of you're making 1% improvements in the sort of Sky cycling team, which I always analogize with my patients. So if we can improve things just a few percent here and here, then and this is where diet and lifestyle, I think, are really important. How much do you believe in the sort of male diet, lifestyle, and nutritional side of improvements? How How much do you focus on that with you?
I think it's very important. And I often involve nutritionists because I think actually they're best placed to deal with the supplement business. And I use the word business advisedly because nutrichemicals, as they're called, nutraceuticals, as we know, are freely available. And often a person who's desperate to help, as men often are, will take the view that if one nutraceutical, one supplement is good, well, I'll take 10. And of course, therefore, they can, one Panadol, almost took the headache away. Let's have 3, which is probably okay up to 4. But, as with everything else, you can overdo it. So nutritionists are very, very helpful, not just for the lifestyle, but for rationalizing the supplements. Because, of course, if you take too many antioxidants, then you get into reductive stress, damaging the DNA, just like the oxidative stress. So nutrition is very helpful. They're very helpful seeing a couple and making this a problem shared, where, for example, weight loss and a different nutritional program would be good for both of them. They can share it, not just the eating of a better diet, but actually the preparation of a better diet. It becomes a problem shared, as the whole thing really is anyway. So I think that lifestyle is really important about what we eat and how often we eat it. And of course, the weight loss, as you touched upon earlier. Whether a male BMI, Emma and I were talking about this earlier, whether the male BMI actually precisely reflects the DNA fragmentation, the average fragmentation, it just might be. I feel a little project coming on.
I do.
The BMI of 30 might be represented by the DNA fragmentation, average score of 30, and upwards.
Yeah, I mean, female BMI has been the focus for so long, hasn't it? And actually possibly unfairly so. It should be a much wider discussion and thought process. Those patients that have, of course, high DNA fragmentation, if we go back to that, doesn't have a bearing on the number of normal embryos they'll get in the laboratory?
Not necessarily. I think that's always markedly to do with female age. You will see genetically normal embryos at a rate if you are able to get them to the blastocyst stage, which is the problem with the DNA frag. But once you get them there, the normal versus abnormal embryos is completely led by female age. The problem is if they're taking 6-7 days to get there, they're never going to implant and create a healthy pregnancy like a day 5 meeting milestones would. So the genetics, I just think, is sometimes a red herring as only part of the conversation. And if you are seeing couples with delayed blastocyst formation, you really need to be thinking outside the box.
And the challenge we find as well is often patients that are getting those embryos, or let's say they're in a young cohort, so they've never had any PGTA or genetic screening, or perhaps they're at the other end where they're in the older age group and have had genetic screening and they're getting normal embryos, but then they're not working. Now, you two have spoken a bit about the influence of sperm that might be sitting in the background there within those numbers. Could you explain that a bit more? Or is that something that's just sort of a working theory?
Oh, so much of what the three of us do is a working theory. But which basically means we can't measure it.
No.
That's what a working theory is. But it has often occurred to me as I have watched what has happened with PGTA, genetic screening of embryos, and the embryoscope. Somebody like me can reflect upon why it is that a euploid, that is a genetically normal embryo, why should that only have a 60-65% outcome in terms of live births? So a working theory, in my mind, is that there may be some point mutations, some genetic mutations, which cannot be measured, as it were, chromosomally. This is merely looking at the letters in the alphabet, not the names and addresses of the people with names beginning with A, B, C, or D. But once we have interrogated, I think, completely the Y chromosome, which only happened a couple of months ago because of the variations geographically, epidemiologically. Once we've interrogated that and matched it with all kinds of unfortunate sub-fertile outcomes, then I think we'll begin to see some little genetic malformations, and there are about 100 candidate genes, I think, am I right?
Yeah.
And then we'll be able to, I think, answer some of that euploid embryo problem.
Yeah.
But the other side of it could well be much more female-based, the endometrium.
Absolutely. I mean, we definitely will spend a lot of time trying to think carefully about that when a patient comes in, thinking about what the actual fundamental problem has been. And as you have those unexplained patients that you can create embryos in, is the actual environment hostile to the embryo? And I mean, the area of endometrial, the endometrial immune profile, reproductive immunology is a really difficult area, because there isn't high levels of evidence that we should be doing any one thing, and it's also not a constant. Much like spermatogenesis, it's always changing, and I think the proximity of any testing you do should be very close to trying to replace an embryo, but with clear discussions with that couple or that individual, that the immune profile of the wound lining, where that delicate interaction between your chromosomally normal embryo and the endometrium takes place, could be influenced by lots of things. But we don't have, despite 10 years, 20 years of looking at reproductive immunology, we still don't have clear answers of what the silver bullet is, if you like, in terms of giving the answer. But we do try very hard, I think, to look at those aspects. And I think patients that we see who have a problem with dysregulation of the endometrium, and there's obviously a mismatch occurring, we'll be really keen to look in either very young patients that have repeated embryos that fail, or the older patient that's worked incredibly hard to find their one chromosomally normal embryo, to put it back in the knowledge that most of the things that we can look at have been tested. But it's very, very difficult, and I think this is probably over the next 15, 20 years, for me, going to be an area we're going to find a lot more out about. I don't know what your thoughts, Emma, are on the laboratory and where that's going over the next sort of 20 years in terms of what we're seeing genetically, because the genetics platforms now are so advanced.
Yeah, they're incredibly advanced. I think we will hone in on what was once known as mosaic embryos being absolutely euploid, and accepting the very much big acceptance that's coming in even in the last 6 months is that mosaicism is just something that's very, very normal in embryos. They are rapidly dividing cell entities that make mistakes, and they can recover from those mistakes. So I think that for me is going to be quite profound. We will end up with more embryos that can be used safely. AI is definitely going to, I think, ultimately, once we start having more conversations like this, ultimately the AI will draw in each element, and we'll start to create things in embryo development processes that AI will be able to detect is potentially linked to the male factor. I think that's coming. I think it's absolutely coming. Our understanding is so advanced to where it was even 5 years ago. So I think that there will become a place where we can almost identify genetic normality through development.
Yes,
I think so.
And Jonathan, in the male side of going back to male fertility here for a while, do you think we're moving into uncharted waters? In fact, that the conversation has moved on with the thanks of, work of urology-wise, the more urologists are beginning to develop an interest in this, or do you think it's still a forgotten area, and we will require social media and lots of other webinars, and I guess what we're trying to do here to try and really fly the flag of trying to improve people's awareness about what might be there in the background?
I think that there are some very significant changes. I would say in the last 5 years, because of male fertility platforms, because people are speaking to each other, because men who have felt traditionally, and indeed at the present time, emasculated by all of this, frightened of it, introverted by it, are beginning to be able to talk about it. just as women have talked about their fertility forever. So that's important, because it, like so many things in medicine, it is our patients who fundamentally lead us. Our patients don't read the learned journals. And if the learned journals are talking about evidence in fertility where there isn't any, our cleverest patients pick up on that quite quickly. So them talking to each other, their shared experiences, I think, has done a great deal to move this forward. And as the patients move it forward, so the doctors pick up on this, and there is more interest, there are more patients to be seen. One of the problems for urologists is very, very simple, and that is that if a high percentage of infertile couples are hidden from urological view, because the country's view, the National Health Service's view, is that there's only one solution, and that's IVF or ICSI, then that doesn't allow many of these men to be out there in the clinics where young urologists can learn. Maybe from older urologists, but where we principally learn from is the patients.
But profoundly on that, I think my experience now, having spent so much time talking to patients over the years, is because of people like us and male fertility platforms and social media and all of that, the conversations I'm having now involve the men. And before, predominantly, I didn't even meet the male partner. And actually, he didn't want to talk. He didn't want to have those conversations. It feels like we're in a very positive space now where couples are approaching fertility treatment as couples. And I think that's because the landscape has changed around the conversations that are more accessible and more appreciated as being probably the correct format. And again, opening the narrative and making it just more normalised for men to be able to speak about this. I now find myself having much more productive conversations with patients where the man is sat with his partner as part of this journey rather than a bystander. And I think that that is going to push this forward quicker than anything we can do.
I think that's a great place to end this. The fact that we three are in this room, and the fact that men and women, of course, are seeing Ed, because they always did, are seeing me when they seek me out, but actually are seeing the person together who has been dealing with their embryos. I think, this can only go upwards from now.
I agree.
Thank you.
Thank
both.
you.